Good morning. My name is Zitan Wang. I'm assistant professor at Northern Illinois University. On behalf of the Informs Chicago chapter, I'd like to welcome and thank you for attending this webinar. This is the second of the COVID-19 webinar series that we are hosting. Today, we're very pleased to have Dr. Sheldon Jacobson to give a talk on risk-based thinking in a COVID-19 world. Before we move on to the presentation, please be reminded that this webinar will be recorded and we will share the recording to you hopefully next week. Please leave your questions and comments in the chat box, and in the end of the presentation, I will pass your questions to Dr. Jacobson. I'm pretty sure that many of you have known Dr. Jacobson very well, but please allow me another minute to introduce him. Dr. Sheldon Jacobson is a founder professor of computer science at the University of Illinois. He has a bachelor's degree and master's degree both in mathematics from McGill University, and an MS and PhD both in operations research from Cornell University. From 2012 and 2014, he was on leave from University of Illinois, serving as a program director at the National Science Foundation. His research interests span theory and practice, covering decision-making under uncertainty and optimization-based artificial intelligence, with applications in aviation security, public policy, public health, and sports. He has been recognized by numerous awards, including a Guggenheim Fellowship, the IISE David F. Baker Distinguished Research Award, and the Informs Impact Prize. He is a fellow of AAAS, IISE, and Informs. He also serves as the founding director for the Institute for Computational Redistricting, ICOR. Now, please join me in welcoming Dr. Jacobson.
Well, thank you very much. I'm going to put up my slides and get things rolling. There we go. Except we haven't shared. I have to go back and share my screen. There we go. And, doesn't show what I wanted to show. Let's do phone. There we go. All right. Let's go to the beginning. Into slideshow mode. There we go. Excellent. Well, good morning, good afternoon, and in some cases, good evening for those of you who are joining. We appreciate you being here. Thank you for the invitation. It's a pleasure to be able to talk with you. We're all living in a different world right now. Some of you may have rolled out of bed a few minutes ago, or some of you are planning to roll into bed after this talk. I'm not sure which one is the case, but we've all been affected by COVID-19. It's been going on now for several months, and it certainly, people in the operations research community, it has affected our thinking, our living, and for many of you, your research, and how you can in fact contribute to the dialogue of understanding how we can live a little better in this COVID-19 world. So I have a lot of expertise in risk-based analysis. Our original contributions, which were funded by the National Science Foundation just after September 11th. In fact, it was funded before September 11th. It started September 1st, 2001, 10 days before September 11th, brought a risk-based concept to aviation security, and it eventually led to TSA PreCheck. And I believe that that kind of thinking has tremendous value and benefit today as we think about so many facets of how we are transitioning our world into a new normal, because we're not going back to anything. Anybody who talks about going back to what we had, I think, is delusional. What we're really talking about is redefining how we live, how we think, how we act, and how we behave. And I believe risk-based thinking can contribute quite a bit to that. So let me give you a very quick summary of how we got here. Back in November, there was this report in Wuhan, China, of this novel coronavirus. The Chinese government took some very draconian, what we thought at the time, action by quarantining large tracts of area and populations, enormous cities. And we thought, how could you close down cities? Well, stay tuned. It happened here in the United States. Not quite in the same way, but certainly in the same spirit. And The good news was that the Chinese government was able to limit the spread of the virus in China, but the bad news is it has escaped and started to affect the world. And now we're in a situation where we have millions and millions of cases and hundreds of thousands of deaths that we're watching occur. So here's some numbers. I picked these out from May 19th, and we see that the world had slightly under 5 million cases at that time, a little under a third of a million deaths. Almost 2 million had recovered at that time. In the US at that point, it was around 1.5 million cases, almost 100,000 deaths, and a little over a third of a million recovered. But if we now fast forward to this morning, we're now pushing 10 million cases, almost 500,000 deaths. We should hit 500,000 deaths probably by Sunday, and over 5 million recovered. In the United States, we're at around 2.5 million cases right now. We've just crossed 1/8 of a million deaths, 126,000 deaths, and over 1 million people have recovered. At some point, in fact, the recoveries, which increase each day, are actually more than the new cases, which of course is a good thing. So if we do some simple projections and say, well, what are we going to get from all this? The numbers are pretty bleak, but they shouldn't be surprising in the sense that if we averaged 800 deaths per day for the rest of the year, which may be a little high, we end up with around 250,000 deaths by the end of the year. If we average 600 deaths per day in 2021, that will bring us all the way up to 470,000 deaths. And then if we average 400 deaths per day in 2022, it brings us all the way up to 600,000 deaths. And you may say, well, gee, these are big numbers. But of course, the potential that we will have an effective treatment or potentially a vaccine, I'm more confident we're going to get treatments before vaccines. Coronaviruses are notoriously difficult to develop vaccines for, and I'm hoping the science is going to be able to make it happen. But effective treatments, I think I'm more optimistic on, and these numbers would come down. But when you see projections of this order, they're very much in line with what we've seen in many other models that are out there. So these are the ones that I've put together just to get a sense of where we're heading and what the possibilities are. So some lessons that I think we can think about in terms of this is that at the end of the day, and this is based on looking at previous pandemics, we should see 30 to 60% of the US population getting infected. And this is based on how contagious it is. This is nowhere near as contagious as measles. It's more contagious than the seasonal flu, and you reach a certain stability or herd immunity point somewhere at this point between 30 and 60%. The interesting thing about the literature which I follow is that anything that I read today may be completely obsolete in 2 weeks or even 2 days. So I have to continue to update the information because we're still getting a handle on what's happening. The infection fatality rate people anticipate having is around 0.6%. So that means 6 deaths for every 1,000 infections. But what we often read are the cases, and cases and infections are very different. There was a report that just came out today from the CDC that for every case, there may be as many as 10 infections. I think that's a little high, but it's probably not all that far off. It could be 4, 5, 6, or 7. And that's what brings the case fatality rate down from where it is right now in the 5% range down to around 0.6%. The other thing to note is that the demographics of risk are very, very different than what we've seen in previous pandemics. For example, in the Spanish influenza of 1917 and 18, the most hit group was 20 to 40-year-olds. They were the ones who were affected the most because the immune system response was so virulent. That is actually what killed the people. We're seeing here that ultimately, if you're older or if you have an underlying health condition, that seems to be an indicator for a bad outcome. So as we pointed out here, people who are older, above 65, and I'm happy to report I'm not there, but nonetheless, if you have an underlying health condition, diabetes, heart, any kind of cardiovascular condition, hypertension, they're discovering that if you smoke, that's not a good thing. If you're obese, that's not a good thing. These are all things that seem to indicate to a higher fatality rate. The thing is, at this point, we really have limited effective treatments. Remdesivir is the only one that has been approved by the FDA, and it reduces the hospitalization days. The thing that makes this so tricky is that there's so many asymptomatic or mild cases. Numbers we see for people who are completely asymptomatic were maybe 40%, which is surreal that people could be infected, still contagious, but show absolutely no symptoms. At the same time, if you count into the mild carriers, then we're in the 80 to 90%, which is a little more consistent with the CDC numbers as we're seeing here. In fact, theirs are even more optimistic than that in terms of having more asymptomatic or mild case carriers. So this is a very tricky virus in terms of managing it at the population level. So what are the countermeasures we have? Well, we all started out with stay-at-home orders or travel-in-place orders. I'm sure a number of you have been working at home. I'm at home right now. That is our open area. To one side is our living room, and the other side goes into our hallway. So welcome to my home. I'm happy that you're with me today. But the non-medical medical countermeasures that are available now, once we now are released from our stay-at-home orders, are hand hygiene, social distancing, hugs, kisses, and handshakes may be the thing of the past, certainly in the short term, but who knows about the long term. And then there are face masks. I just had an op-ed which appeared in The Hill talking about the fact that we need to wear our face masks correctly. And this is very, very critical and important. And then, of course, testing. We want to know who is infected. So looking at who's currently infected, testing for antigens through the PCR testing, or if they have been exposed and they've developed antibodies. This is useful information, both from an epidemiological point of view, but also to know where you are in terms of your health status as a population. So what's the end game? Like I said, I believe 30 to 60% of the population are going to get infected. So we're talking about anywhere between 100 and 200 million people in the United States will get infected at the end of the day. And you say, well, gee, that's awful. But once again, this is not killing 20% of the people. It could be 90 or more % of the people are asymptomatic or have mild. So if you just run the numbers down, you come up with the kind of numbers that I gave you before. On the low end of 600,000 people dying through 2022, which is the number I showed before. And on the higher end, if you're a little more pessimistic, or it turns out we're underestimating the virulence of the virus, we could get up to over 1 million people dying. But the thing is, if we get effective treatments or ultimately a safe vaccine, that can be a game changer quite aggressively. So what have been the challenges? Now, the challenges we're going through right now are reopening communities without creating the surges in the hospitalizations. Because if we start to see the ICU beds filling up and we don't have the capacity, that's when the outcomes start to get even worse. You want to give people at least the chance, if they're having a respiratory distress, to be able to survive it. And we want to create an environment that limits the spread of the virus until we find either the treatment or the vaccine. And that means ultimately bringing down the basic reproduction numbers. Since we can't do it with stay-at-home orders, we have to do it by social distancing, by face masks, by hand hygiene. If we do that, we can locally bring it down. And that's why these non-medical countermeasures are so critical. So what are some questions? I'm going to talk about a couple of them. One is, how should aviation security be modified during the COVID-19 pandemic? Aviation security is something that I've studied for over 2 decades, and it interests me, and there's a lot of interesting information going on. I've written a couple of op-eds associated with aviation security in this COVID-19 world. And then, how can we bring risk-based thinking to the reopening dialogue and discussion? Because I think there's important lessons that we can learn from there and see how we can apply it. So let's talk about aviation security first. It's designed to protect the air system from malicious intent of acts of violence, which are serving to harm people and property, causing hysteria, anxiety, a variety of things. And the process of risk-based security, which is the work that we did for over 2 decades now, is matching security resources with the level of security risk, so that ultimately what we're doing is balancing the security of the system with the efficiency of the operations. So it's a very classic balance problem. If we want more security, we may have to degrade efficiency. If we want more efficiency, we may have to degrade security. So this is the basic idea of risk-based security. Now, if you think about aviation security, and I know you've all flown at some point, the first thing you think about is, well, how does social distancing fit into all this? And as we know, social distancing and aviation security are completely incompatible. Now, there's a lot of things that are incompatible with social distancing. You know, in restaurant seating and going to bars, going to sporting events. These are opening universities for in-class education. These are all fundamentally incompatible with social distancing. So in spite of that fact, we still have the problem. It's like having an NP hard optimization problem. It may be intractable to solve, but you still need a solution. And it's in some sense, we have the same metaphor here. So the purpose of aviation security is basically to protect the air system, as we said. And the objectives in the pre-COVID world were to maximize the security of the system while minimizing passenger inconvenience. But in this new COVID-19 world, we have a third objective. We still want to maximize the security. We still want to minimize the passenger inconvenience, but now we want to minimize virus exposure. We can't eliminate it completely, but now we have a third objective. And going from 2 to 3 objectives makes the problem much more challenging. So let's look at TSA COVID-19 infections. And this was as of May 20th. The numbers today were more closer to 650 cases. And this is among TSA personnel. And in fact, the deaths went from 6 down to 5. I don't know how that's possible, but the federal government can do anything. And most of the people, of course, have recovered, as we would expect. So the question is, how many passengers were infected by these TSA officers? Because you're funneling people into a very close area. So the TSA made some decisions. They were going to compromise security to hopefully enhance the public health safety of the passengers. So risk-based thinking says, well, let's balance security and efficiency typically, but now we have to add in the health component. And now you want to align the security resources and the procedures to meet all of these objectives. But of course, you know, having 2 objectives is hard enough. Having 3 makes it even more challenging. So now what you have to do is you have to make compromises. So let's look at what some of these compromises are. First, let's do, actually I want to go back and make sure, yes, okay. Let me give you a Aviation Security 101 on risk-based thinking. It's actually a very simple idea mathematically. And the challenge, of course, is applying it. So I'm going to go through a very simple exercise. This is basic undergraduate probability, and you'll be able to see exactly what risk-based thinking is. So the terminology I'll use is a threat to the air system, and then we'll also have known risk passengers and unknown risk passengers. Eventually, we're going to translate this into the COVID world. So we can apply the law of total probability to compute the overall unconditional probability of a threat by conditioning on whether we have known or unknown passengers, and then just applying the law of total probability in a rather straightforward way. And then we make certain assumptions. So if we look at the data available from the TSA, around half the people who are screened as pre-check and half are screened as non-pre-check. So the probability of being a known risk versus an unknown risk is around 50-50. But we also know that if you're an unknown risk, the probability that you're a threat is significantly larger than if you're a known risk. The known risk is because of the background check that you voluntarily subjected yourself to, which means that if you're a known risk, the probability of a threat is actually quite small, almost negligible. We'll call it epsilon. So under these assumptions, then we can then compute the probability of a threat by the expression we have here, where we know that if you have an unknown passenger, the probability of a threat will be in fact the dominant term. So given that fact, we can now say, given that we have threats, what is the probability that it will come from a known traveler, someone that we in fact have vetted through pre-check? We run through the numbers, apply Bayes' theorem, and lo and behold, we come up with an expression which suggests that the people who are known risk just are, in fact, given that there's a threat, the probability they'll be a known risk person is very, very small. which means the probability they'll be from the unknown group will be very, very large. And we can do the same thing, of course, here, as I said, by looking at the unknown group. The bottom line is that when we see threats, they are going to be coming from the unknown group disproportionately more often than the known group. And that's really the basic idea behind risk-based thinking, that by partitioning the passengers between risk and known risk, or unknown risk, we're able to, in fact, apply the appropriate resources to be able to, in fact, detect these threats. So the takeaway from all this is risk is concentrated in the group of unknown risk passengers, so throw your resources there. But the corollary to this is that threat can be of any type. It can be a security risk, or it could be a health risk. And now we add a new dimension to the risk-based thinking to help us, in fact, use risk-based strategies in a post-COVID-19 world. So now let's apply the same reasoning to reopenings. So we're in a situation that governors are, taking away the stay-at-home orders. They're saying, we're going to go back. We're going to let people out. You have to be responsible and take whatever actions are necessary to prevent the transmission and spread of the virus. But it becomes much more of a personal responsibility rather than a societal responsibility. So now let's define threat to be a poor outcome of a COVID-19 patient. Let's now define the known risk people are people who are in the low risk group, people who are in their teens, 20s, and 30s, even people who are older who have no underlying health conditions would be in that group. And then you have the unknown risk people, and we'll call those the high risk people. Those are the people who are over 65 or people who have a known underlying health condition like diabetes, like hypertension, and so forth. So we're going to just redefine what we mean by known and unknown risk within this COVID environment. We can do exactly the same thing as we did before and come up with an expression for the probability that the COVID-19 has a threat, which means we have a bad outcome. And then we can condition on whether we have low risk or high risk people. So we're doing exactly the same thing as we did before. The assumption we're going to make now, though, is that there are many more low-risk people than high-risk people. If you look at the people who have the underlying health conditions or who are over 65, they're approximately, and I'm using a reasonable guesstimate based on some demographic data I have, that it's around 3/4 of the people in the population. So the probability that you'll be low risk is around 3 times the probability that you'll be high risk. It still turns out that if you're high risk, the probability of a bad outcome, which we define as threat, will be much higher than if you're low risk. So under this assumption, we can come up with an expression for the probability of bad outcomes. And it's the same kind of model we saw before for aviation security. So nothing really changes here. But then we applied Bayes' rule in the same way. And given that we have low outcomes or bad outcomes, a threat, what's the probability it will occur in the low risk group? And we see that that number will be very, very small. And the nice thing is that the CDC provides all the data to be able to compute all of these. This is not something that we just have to fudge. The data is being collected, literally updated every week by the CDC. And all I have to do is take it from the CDC and come up with my exact numbers. And when we then look at the high risk group, well, that's the group that you want to be careful of. And ultimately, the poor outcomes are going to occur in that group, which means that as we reopen society, we want to prevent as many bad outcomes as possible. The way we do that is that the people who are high risk, and you have to, in some sense, self-identify yourself as such, you should quasi stay at home still. You should limit your exposure to people in the low risk group who are running around. In fact, if you look in the last 48 hours, we've had more cases of COVID-19 than any other 2 days since this pandemic began. But if we look at the demographics of this group, they are predominantly low risk people who are getting infected, which means that when we look at the outcomes that will occur, we will most likely, based on the data we have so far, not see as many bad outcomes as we were seeing early in the pandemic, when people in senior living centers, people who were at higher risk, were being exposed, being infected, and ultimately having bad outcomes. So the fact that we have more cases doesn't concern me. I want to know how many of those cases, because testing now is so ubiquitous. My wife and I went and we got tested a few weeks ago. You just drive up, you don't have to have any symptoms. There was a time that the only people who were being tested were people with symptoms. That's not true anymore. So by definition, you're going to catch some of the asymptomatic people who notoriously have no bad outcomes. And then people who are lower risk, may get tested, they're going to be positive, but they're going to have mild symptoms and very good outcomes. So I'm less concerned about the number of cases. What I want to know is how that is translating into hospitalizations, ICU beds, and ultimately deaths. And over the next few weeks, we're going to find that out. But based on risk-based thinking, if that principle is being applied, we should not see the kind of surges we saw in New York City, in New Orleans, in Detroit, and Chicago for the current increase in the number of cases. So what this means ultimately is the countermeasures that are employed really have to be designed to protect the most vulnerable groups, because this is ultimately where we're going to have the biggest problems. Cases don't bother me. What bothers me is when people end up in ICUs. And we have a better picture of who's going to end up in an ICU. Are we absolutely certain? Well, no. But we're getting pretty good. We can predict probably 90% of the cases. And that, in fact, is giving us a tremendous amount of information. So these kind of ideas of a risk-based approach is effective enough to be applied across many aspects of our society. Many of us
For some reason, the video signal lost. Now I can hear you now.
If you can unmute me, because I'm doing this artificially.
Let me unmute you.
Very good. Excellent.
Yes, I can hear you now.
So the same kind of idea that applies in aviation security, risk-based thinking, can be applied.
Please share a screen, Dr. Jacobson.
Oh, I have to go back and share it. Okay.
Yes.
All right, hold on a second.
Folks, I'm sorry for the connection issue. Please bear with us for a second.
Yeah, here we go. Share screen. Okay, share. Oh, all right. Just thinking. Screen share. So the key idea is that risk-based thinking can apply much more broadly than just aviation security. It can apply to our own universities, where the students, the 18 to 22-year-olds, have phenomenally good outcomes and do not need the protection as possibly the senior faculty. So in this particular case, the university has to protect the faculty, not the students, from bad outcomes. This also occurs, for example, in churches and faith-based organizations where the average age is on the order of close to 60 years of age. So you have to really think very carefully of the cohort of people who are ultimately going to end up being exposed and the potential outcomes that come from it. There we go. And we're going to go. So what's the message from all this? And the message is that risk should be managed. You shouldn't run away from it. You shouldn't avoid it or ignore it or anything like that, because if you do, it will control you. And that's why at universities, as I said, protect the people who need the protection. And the majority of students just do not need that protection. That a case is not a death sentence, it just happens to be an infection. And it's conceivable that 80, 90% of them will be asymptomatic. The other thing is you want to, in avoiding risk, what you do is you ban all the activities in the name of protecting the most vulnerable people. And I am not a fan of hijacking openings to protect the most vulnerable. The most vulnerable have to be protected, but there are ways to do that without completely hijacking the entire reopening process. The media doesn't want to talk about this, but the data supports all of this. I was talking to a sports writer yesterday who's going to talk about college football, and there's going to be deaths in college football. But the deaths are going to be less than what you typically see from accidents or players just have health issues which come up. It's going to be no worse than what we've seen in previous years. And he said, nobody's talking about this. He says, well, nobody's looking at the data. And we're people who look at data. So some of the modifications, if we go back to aviation security, is that the TSA officers now wear face masks and the passengers wear face masks. And you're also allowed to bring a sanitizer bottle up to 12 ounces. Now, this does slightly increase the security risk because someone wearing a face mask may end up not being the person who they're presenting themselves to be. Once again, very low increase in security risk. Having a sanitizer bottle could be a potential explosive liquid, but it does reduce the health risk. And these are the trade-offs that have to occur between security and health. Now, the TSA taking temperatures of the passengers. This increases the security risk because what it does is it diverts attention away from their job, which is security, but it does not reduce the health risk. It turns out to be a horrible idea, and I'm thrilled that it has not been implemented. Some airlines are doing it. I think it's a waste of their time as well. You can basically hide any kind of temperature increase because, take ibuprofen or acetaminophen, and you'll be able to do that. It should not be a problem. But so ultimately, if you're going to make a change, you should do it so you're getting some benefits somewhere among the objectives. And taking temperatures does do nothing to improve any aspect of the process. The airlines have also made some modifications. So the crews and the passengers now wear face masks. That's a good thing. They deep sanitize between the flights. That's another good thing. The air system, which circulates air through the cabin, actually has great filters in it, at the same level as in hospitals, and it's wonderful for preventing the transmission of the virus through the air. You want to space the passengers as much as possible, and also make it such that there's no penalty for making a ticket change or a flight change. And they've instituted all of these. These are things that we talked about even before they instituted them, and ultimately reduces the health risk to the passengers and the crew. So these are positive changes that the airlines have made. And some proposed TSA security modifications, and these are ones that I have proposed, is that if you have global entry, which is a even more serious and an in-depth background check, because they have biometric information available about you, you should be treated like a flight crew and require no additional physical screening at airports. They have not implemented that, but I would think that this is a very, very positive direction for removing the touch points between the security officers and the passengers. And then the other thing is that the TSA ended by congressional mandate something called managed inclusion, which gave the TSA officers the flexibility to put a few passengers in the unknown risk group into the pre-check lanes. I would advocate that that be brought back temporarily. It does slightly increase the security risk, but the benefit you get is less touch points for the passengers and ultimately a little better health reduction or health risk reduction. Oh. Why are we not? Okay. The other thing the TSA should consider doing is, of course, is encouraging more people to join pre-check, because the pre-check lanes have fewer touch points, and reducing the cost from $85 for every 5 years into something close to zero makes sense. And then also using biometric identity validation is absolutely critical. They've been slow in doing this, and now we're paying the price for that. But I've advocated this for several years, and I'm still advocating for it. So if you think about non-risk-based reopenings, it means that everybody's treated the same. And if you treat everybody the same, a so-called one-size-fits-all approach, you're rarely going to satisfy everyone or even anyone. What we need to do ultimately is we want to find, those few, that area of the haystack that causes the potential problems. So if we're able to partition the haystack in a manner that we know the people who are at high risk and we know the people who are at low risk, the low risk people can tolerate more exposure, so let them be exposed. The high risk people cannot tolerate that exposure. We want to be much more careful with them. I think we're moving towards that. And like I said, in some sense, the increase in the number of cases in many states may be a symptom that we're actually moving towards a more risk-based reopening. But the media is not reporting it as such, and it creates an anxiety that we're going to have the same kind of bad outcomes we saw with New York City in July. And the fact is, it's not clear that that will happen. So for high-risk people, they really have to be more careful. I advocate that they continue to shelter in place based on a risk-based model. Also avoid large groups of people, wear masks. They have to continue to be very, very careful because if they do get infected, they have a high incidence of death for people, for example, which are over 65. And once again, it depends on their underlying health conditions. You can have a 10 to 15 to 20% rate of fatality, a death rate for that group, depending on where you are in age as well as in health condition. And your chances are best if you can end up in an ICU on a ventilator. So you want to make sure that hospital capacity for ventilators and ICU beds is sufficiently there. The ultimate goal, though, is you're trying to reduce the local basic reproduction number, the so-called R0. Everybody talks about this, and they think of it very globally of what R0 is. But an R0 is in a community, and that's the one you want to focus on. You want to get it down as low as possible. And social distancing, hand hygiene, face masks are the way to do that. It's the only tool we have, and if we choose not to use it, then if you're a low-risk person, it won't affect you much, but it ultimately affects the high-risk people. We want the virus to die out on its own. The best way to do that locally is get the basic reproduction number down below 1. So anything that can be used to shrink the unknown or elevated risk haystack has positive health implications. That's why it's important if we do get treatments, it will actually change that haystack size. Anything that we do scientifically, public health-wise, non-medical-wise, anything we can do along those lines will have positive population health implications. The key is avoid this one-size-fits-all mentality. It's very ubiquitous in government, but it just doesn't work. The other thing we have to watch for is unintended consequences. I mean, we've seen social unrest, an increase in crime, domestic violence. I mean, the whole incident which occurred in Minneapolis, horrific things, looting. And I think some of these are unintended consequences of people just getting frustrated and it percolating out in unexpected ways from stay-at-home orders. We can't just look in one dimension of the objectives. We have to look at all the possible dimensions. So as a last word, and I'm talking mostly to students, but I'm talking to everybody, I suppose, is I always call it a call to arms. We at Informs are people who have had great opportunities. We have tremendous skills and abilities and talents, and it's important that we use it for the greater good and for society. And I believe that if we want to affect some major societal changes, ultimately it begins in the grassroots with the individuals. And I've done that in my own career. I've dedicated my whole career to public policy problems. I have a list of them here now. And now COVID-19 gets added to it, although it's kind of the same ideas we use in risk-based thinking for aviation security. And I highly encourage each and every one of you to take that very seriously and consider ways that you can make a difference. COVID-19 is a great opportunity for that, but there are other opportunities. And one of the areas that we are very active in is computational redistricting. the census that is going on right now will eventually produce new congressional maps. And we're trying to contribute to that dialogue as best we can using stable, sound, algorithmic concepts and ideas to inform the dialogue. So I encourage each and every one of you to find problems that you can add to your portfolio of research so that you can make a difference, you can contribute, and you can in fact make the world a better place. So I'll end with the best time to plant a tree was 20 years ago, the second best time is now. So I highly encourage each of you to go out and plant a few trees because A, you have the ability to do so. I'm fully confident that you are all wonderful farmers and gardeners and can grow wonderful trees. But the time to do it is now. And COVID-19 may be the encouragement you need to begin to think about that. But there are so many other problems and issues on the horizon that by all means, think very broadly about them, because I know that each and every one of you has the potential to make a difference. So I say stay safe, and I want to thank you very much for the opportunity to share with you my thoughts on risk-based thinking in the COVID world and how we can do better and make a difference.
Thank you, Dr. Jacobson, for such an informative webinar, and we are now open to questions. For the attendees, please use the chat box to leave your questions and comments. The first question I've seen is from Sarah. She says, in the aviation application, the old high or unknown risk population represented risk to others by, for example, terrorist acts. Now the risk is to oneself, for example, the vulnerability to the disease. Can you comment on how the same analysis applies here?
Well, that's a great question, because true that if you let a terrorist onto an airplane and they cause damage, many people will be affected. But even when we get infected, we ultimately can spread it to other people. So there is a risk factor associated with it. I do define outcomes as poor outcomes for the individual, but those poor outcomes also use health resources which deplete it, make it unavailable to other people who can benefit. So although I focus on the personal outcome, the reality is there is still a bigger outcome that affects society. So it's a great question, and it certainly is well worth thinking about, and it gets incorporated into all the data.
The next question is from Paul. The question is, the experiences of other countries seem to suggest that both cases and deaths can be controlled. Are there examples where cases have spread among low-risk populations without significantly affecting high-risk populations?
We've actually had the flip of that, because in certain European countries where they have an older population than we have in the United States, what we're seeing is that death rates are significantly higher, like in Italy, for example, in Spain. Those are two good examples where the average age is around 7 or 8 years higher than the United States. And you see exactly that occurring. When we start to move into countries, potentially in Africa, where the average age is much lower, it'll be interesting to see what the case fatality rate will be there. Now, they don't have a strong health infrastructure, so that can in fact cause problems. But I think we're still learning a lot about that. And the answer at this point is we don't know, but we will eventually know. Unfortunately, it's very hard to predict that.
Thank you. The next question is from John. The question is, if airplanes have such great airflow systems, then why is social distancing on airplane recommended?
The reason is that you don't want someone in seat 5C to get infected with someone in seat 17D. And the airflow in the cabin will in fact mitigate that. But if someone is sitting right next to you, then the airflow issue becomes less critical. And in fact, it's less of a mitigating factor. So it depends on where you're positioned on the plane.
I'm having another question from Luis. This person comes from Rio de Janeiro in Brazil. The question is, it seems to me that your Bayesian analysis can be extended to contexts other than air transportation within the framework of the pandemic. what do you think? What's your comment?
Absolutely. I mean, Bayes' theorem is universal. It's used in medical testing, it's used in criminal analysis. The same concept and idea of partitioning your population has wide and impactful value. And I'm a believer of it, obviously. And that's why when COVID-19 started to arise, I realized not everyone is created the same, and not everybody is going to respond the same, which means that a natural concept of risk-based thinking should add value. Now, the extent of the value in any of the applications will vary. In this particular case, I think it adds tremendous value. So I agree with your point. You know, it could be applied much more broadly, and I encourage you to think about that.
I'm looking at another question from James. The question raised, a major challenge appears to be getting decision makers to shift from one-size-fits-all decision-making approach. Is progress being made on this front, and what can be done to accelerate this shift?
It's a great question. I think decision makers, especially people in government, are reticent to move away from the one-size-fits-all because of the perception of fairness, that we want people to be treated fairly. And unfortunately, in that particular case, people are going to die because of it. People are going to die if we treat everybody the same. Everybody is very different, and we have to accept the fact that people are different. You know, personally, I've written op-eds, I've done interviews with newspaper and radio and television journalists, and I encourage each of you, if you can contribute to this dialogue, it is absolutely critical, because there's so much noise about everybody being treated the same, and every case is the same. A 19-year-old who's healthy and a 85-year-old with underlying health conditions, if they get the disease, I have more confidence that the young person is going to survive and the older person may not. The other thing to keep in mind is that even if you look at the 85-year age and older group, for those who get it, they still have a survival rate, and this is based on some data I looked at this morning, of around 70%. Now think about that. 70% of the people who are over 85 actually survive. If you listen to the cacophony in the media, it sounds like everybody's dying. And that's the worst cohort, the 85 years of age and older, and 70% are surviving. 30% are dying. It's not a good percentage, but 70% are surviving. Now you go down to the 18 to 24-year-olds, and of those who get it, 99.99% are surviving. Completely different analysis. That difference means if we don't treat people differently, we're ultimately going to poorly use our resources, underutilize resources, and end up with worse outcomes if we have used the appropriate resources for the appropriate people.
I have a question of myself.
Sure.
You have talked about the suggested modifications in TSA Aviation Security. What about the university environment? I think many of our audience live in the environment of campus. Can you elaborate on your suggestions or modifications of operations in universities and even high schools, primary schools in that regard?
Okay, well, that's a big question. I'll start with universities. With universities, once again, the at-risk cohort, the older faculty and staff, and you want to protect them, which means that it's conceivable that you can have a class full of students where the professor or the lecturer is actually broadcasting remotely their lecture to the students. Students are physically present. We think of online education that everybody's online. Well, you can only have, it's possible to have one group online. In this case, the lecturer and the professor, while the students are mingling with each other. I talked about this in an op-ed back in April in the Madison, Wisconsin newspaper, talking about Big Ten schools and large public universities having to deal with this issue. In terms of the risk to the student population, it's quite small. Mitch Daniels had a very nice op-ed in the, I think it was the Washington Post. And at Purdue, if I understood him correctly, every student coming in is being given a set of masks, hand sanitizer, as well as a thermometer. So they have, in some sense, a safety kit. and they will in fact monitor themselves, but the intention is they will roam around, and there will be a handful of bad outcomes, but not very many. And if you do have a bad outcome that it's percolating, with these resources available, then the student can self-monitor themselves and take the appropriate action. If you try and prevent every single case from occurring, there's going to be panic on campuses, universities are going to close down, go online, and I think that threatens the viability of those institutions moving forward. The students won't be happy, the faculty won't be happy, the alumni won't be happy, and we're going to see a reshuffling of reputations of institutions because of COVID-19, of how we deal with this. If we run from risk, we're going to self-destruct. If we face it for what it is and meet it and mitigate the risk, we can get through it and get to the other side. But we have to go through potentially an uncomfortable period and accept the fact that the University of Illinois, about 40, 45,000 students on campus, it's conceivable we'll end up with 5,000, 6,000 cases, but very few bad outcomes. A handful, but very few based on the data. For K to 12, the big challenge there is you can't ask a 4-year-old to take personal responsibility. That particular group is also not at risk. However, the risk that they have is when they go home to their parents. And that's why you want to do as much to mitigate the cases as possible, but also there's a certain amount of cooperative education that has to go on between the schools, between the parents, breaking classes up so that they're smaller, potentially having a morning and afternoon cohort, potentially bringing in weekend classes. I mean, there's a lot of things on the table, extending the class hours. All these things are possible, and I think each school district's going to have to think very carefully of how they want to implement it. But the risk is less to the students, much more to the teachers and to the parents when they go home, and then their grandparents if they interrupt them. Those are the risk groups, and we have to look at that much more holistically if we're going to be able to make good decisions.
I think it comes down to the concept of managing the risk instead of completely avoiding the risk, which is not possible in an environment like universities or K-12 schools. I think one of our audience is Roger sending his comments. In college, it's not the issue with the professors. They are at higher risk.
That's right.
Exactly.
They're the ones at risk, which means they may stay off campus, broadcast from a safe space like their home or even their office, their lectures, and the students will be in the classroom in their normal way, practicing social distancing, wearing masks. So you want to take appropriate precautions, but at the end of the day, what's going to drive so much of this is the risk cohorts based on age and underlying health conditions. And that's something that we know now and we can take responsibility for.
Okay. Would you like to comment on the feasibility or effectiveness of enforcing the risk-based measures in the long term in the society? Because in the airport environment, it's easier to implement all those measures with TSA, and also in the university, it's a local environment that can be easily managed. But what about the broader society?
Once again, yeah, what goes on at an airport through airport security and in the air system in general is far more homogeneous than what we have in society. So your point is well taken. Ultimately, this does come down to personal choices and personal freedoms. And there's going to be some people who will say, I'm not going to wear a mask, and nothing you can do to get them to wear a mask. I do believe that a lot of the enforcement cannot come through laws that are enacted or from the top down. They have to come from the bottom up. If stores, if commercial establishments say, no mask, no service, just like many restaurants will say, no shoes, no shirts, no food, same principle applies, then they can in fact enforce it from the bottom up. And that will funnel those people to a different set of establishments while leaving a certain group of them much safer for a large cohort of people. So it has to be done from the grassroots bottom up. It can't be done from the top down. A governor saying, do A, B, and C is meaningless, while if the businesses in a community, if the mayor, the city council make recommendations, people are much more amenable to follow them because they know the culture of the people and they know the culture of the community. They're one of their own. And that is absolutely critical. Now, does that mean we need 100% compliance? Well, it'd be nice to have 100% compliance. But even if we had 80% compliance with face masks, we would find that the basic reproduction number would start to go down locally and may be sufficient to get it below that magic 1, and then the virus will start to die out locally. That's the key, of course, is everything is locally. It's all driven from the grassroots. I'm a firm believer that anything coming from the top down is absolutely meaningless. Things from the bottom up and getting buy-in from the people at the lowest level is the most effective approach.
I think probably last question of the day, because we're close on time. In the end of your presentation, you encouraged us to consider a research career in related directions and areas. Would you like to elaborate on that? For example, the research questions to be answered in this pandemic and in the long-term research directions in risk-based public policy, health operations, and so on.
Well, I believe that each person should find their own passion and what excites you. We can certainly work on industrial problems, improve profit, efficiency, but there's so many problems in public policy that we can contribute to that dialogue. And it may not necessarily result in wealth being created, but it does result in lives being saved. I encourage people to just think about that. It doesn't even have to be based on the approach that I've taken. You can find your own approach. A person I think about is Andrew Schaefer, who introduced the concept of treatment optimization using Markov decision processes. Very different than what I've taken, but made significant contributions to open up a field. Those are the kinds of issues I think that we as a community can address. And I encourage everybody to think much bigger than themselves and see how they can make a difference to make the world a better place. That's really what it comes out to. How can we make the world a better place? When I was at the National Science Foundation, people would talk about and ask about broader impact, and I'd simply say, how is your research going to make the world a better place? And if you can answer that question in 30 seconds, then chances are you have an opportunity. And I encourage people to exploit those opportunities.
Thank you so much for the answers and encouragement. I believe this webinar has made the world a little bit a better place.
We hope so.
I'm sorry that we cannot take more questions because we're close on time. Before we close the seminar, let's give Dr. Jacobson another virtual round of applause and thanks. I also would like to thank all of you for attending this webinar. Please stay tuned for the other events of the Chicago chapter. You can find them on our website. And thank you all again and have a great weekend.